Good morning, everyone. My name is Doris Rodriguez, and we'll get started in just a few minutes while we give people a moment to get situated. So if you need to get anything, please do so now. We'll start in a couple of minutes. I also want to announce that this presentation is available with automatic closed captioning. Additionally, we are providing simultaneous interpretation in Spanish this morning, for which I will now provide instructions for our Spanish Zoom attendees to join. Hoy siempre brindamos servicios de interpretación simultánea para nuestros eventos, igual en persona o en Zoom. Favor de hacer clic en el globo al fondo de su pantalla donde dice interpretación. Luego haga clic en el idioma que desea escuchar, en este caso español. Si tiene, si quiere escuchar solo al intérprete, puede también hacer clic en el Mute Original Audio, que silenciará el audio original. Muchísimas gracias y de nuevo bienvenidos a Sinergia. Estamos agradeciendo de tenerlos aquí. If you can just give me a second to log into the Facebook Live. Alrighty. Before we begin, I want to let you know that we'll be broadcasting today's event live via our Facebook page, and I want to give a warm welcome to those joining us there. Everyone who registered via Zoom will receive a copy of the presentation slides via follow-up email within the next few days. A survey will be shared in the chat at the end of the presentation. We will have time at the end of the presentation for Q&A, and we encourage questions at any time. However, please remember this is a public forum and we are being broadcasted on Facebook. My name is Doris Rodriguez, and I am the Autism Initiative Coordinator here at the Metropolitan Parent Center. A few words about Synergy's Autism Initiative. The Autism Initiative project is funded by a grant from New York City's Council under its Autism Initiative. This project supplements the work of Synergy's Metropolitan Parent Center by bringing an increased awareness to New York City's residents, particularly to the communities with large Spanish-speaking populations, about the growing number of children diagnosed with autism spectrum disorder. Its strong outreach targets families of children with a suspected or known diagnosis of autism who are not receiving appropriate educational, health, and other related services. This initiative will link them to other services and supports that meet the individual's needs of children and their families. I want to thank you. I want to thank all of you for joining us today. We're glad you chose to be with us today. After our presentation concludes, as I mentioned, we'll have time for questions and answers. So if you're joining us via Facebook Live, if you have questions, please place them in the comments section. And before we begin, I would like to introduce our presenter today. I want to welcome Michelle Gorenstein. And Ms. Gorenstein, Dr. Gorenstein, I will let you introduce yourself. All right, go ahead.
Great. So thank you for having me. My name is Dr. Michelle Gorenstein. I'm a clinical psychologist at New York-Presbyterian Weill Cornell Center for Autism and Developing Brain, where I specialize in providing first-time autism diagnoses to adolescents and adults. Prior to joining faculty at Weill Cornell, I was the director of outreach at the Seaver Autism Center. So I've been collaborating with Synergia for over a decade now, and I'm always happy to present and answer questions. So today, let me just share my screen. Today, I'm going to be talking about understanding your child's diagnosis and translating it into advocacy. And I have been giving this presentation a lot because part of what I do is answer phone calls for parents seeking evaluations. And there's always a big misunderstanding of what type of evaluation a child needs, what the evaluation does. So I always enjoy providing this information so families and clinicians or community employees can kind of know what they're referring for. So we're going to start by kind of just an overview of autism, because I always like to make sure that we're all on the same page in our understanding of what we're talking about when we're talking about autism and the language that's going to be used in an evaluation. I'm then going to talk about what a diagnostic evaluation is, what a psychological evaluation is, what a psychoeducational evaluation is, what a neuropsychological evaluation is, what a neurological evaluation is, what a psychiatric evaluation is, and then we're going to end by talking about how do you use all this information to translate it into advocacy for your child. And when we're talking about child, we're going to focus a lot on school services, but we're also going to be focusing on adult services as well. So just a note about language. For those that have been to lots of presentations or are following social media, there's obviously been significant changes over the course of the past decade in language. I personally believe it's an individual preference. Some autistic adults will prefer person with autism. Some individuals prefer autistic person. Um, so you're going to probably hear me use a combination just because when I'm doing a report, I'll always ask the family what they prefer. So just to kind of give a broad overview, and then we're going to kind of do more of a deep dive. A diagnostic evaluation literally just confirms or clarifies an autism diagnosis. You could also get a diagnostic evaluation for another specific thing, but when we're talking about autism evaluations, a diagnostic evaluation is literally saying yes or no to the autism question. A psychological evaluation typically includes an IQ test that looks at intelligence and oftentimes an adaptive behavior scale. And adaptive behavior means one's daily living skills. Psychoeducational testing focuses on academic performance, achievement level, reading, writing, math, spelling, those aspects. And a neuropsychological really focuses on specific cognitive abilities, attention, executive functioning, memory, language processing. And typically, when we're thinking about an evaluation, the diagnostic evaluation is kind of the more limited question. A neuropsychological evaluation is a much broader evaluation. All of these assessments rely on multiple methods. So any good assessment is going to include a clinical interview where the clinician is asking you questions, getting your sense of what's been going on, getting your sense of developmental history. Standardized assessments are things like IQ testing, academic testing. Those are assessments that are standardized in administration. A psychologist is reading from a script. A psychologist has very specific ways to score answers. And then the results are normed on a population. So in theory, and I say in theory, it should not matter who administers a standardized test because it's standardized. That being said, we definitely know some clinicians are just more skilled at getting kids to put forth their best effort, have more flexibility in terms of taking breaks and things like that. But in theory, a standardized assessment, the psychologist, no matter where you get the testing, is giving the exact same prompts and scoring the questions the exact same way. Functional assessments are often used for monitoring progress over treatment because they're not normed based on a population. You're typically comparing a child's score over time to themselves. So as I mentioned, standardized assessments, which is what we're going to talk about a lot today, have standardized measures of administration and scoring, and are scores based on a normative sample. Typically, they're used to show if there's a developmental delay. They can also be used to show if there's a child who's like gifted and talented who scores way above the average. They're typically not super useful in terms of measuring small changes over small amounts of time. I'm going to focus a lot on this at the end, but an evaluation should be looked at as a key to access services. And when you're thinking about what type of evaluation you need, you want to think about what is the question I'm trying to answer? What are the services I'm trying to obtain? So if you're looking for services through the Office for People with Developmental Disabilities, they are very specific about what testing they need. OPWDD requires a psychosocial history that can be done as part of a psychological evaluation, or it can be done as a separate evaluation, typically with like a social worker. So a psychosocial is literally just the parent giving the history, talking about current services, school, medical history, birth history, and current concerns. OPWDD also requires standardized intelligence testing, and they are very specific in terms of what test they will accept. If you go to OPWDD's website, they kind of are very clear. Another thing to be mindful of is every so often tests get updated, and OPWDD requires that the psychologist be administering the current version of the test. So a very common one are the Wechsler scales. So the WIPSI is the preschool, the WISC is school age, WACE is the adult. The WACE just came out with a new edition. So now we're using the WACE 5. There's a small window where you're still able to use the WACE 4, but you do want to make sure if you're doing testing for OPWDD that the psychologist is administering the appropriate test. If you're applying for OPWDD, they require the psychosocial, and then the psychological is going to contain the IQ test and a standardized measure of adaptive functioning. And we're going to talk about what those are. But those are parent report measures of daily living skills. And I'm going to go into more detail. If your child is applying for OPWDD and has an autism diagnosis, they will also need standardized testing for an autism diagnosis. And that could be the ADOS, it could be the CARS. Again, OPWDD is very specific. So 20 years ago, when I started in this field, a psychiatrist used to be able to write a note saying this child has autism, and you would send that in with the IQ testing and the adaptive functioning, and that would be sufficient. OPWDD now requires formalized testing to document an autism diagnosis. Lastly, OPWD requires an onset prior to 22. So as we all know, autism is a developmental disorder, meaning that it's not something that's acquired later on in life. Symptoms are present from birth, even though individuals might not come and get a diagnosis until adulthood. So if you have a child or you're working with a family and the child is 24, 25, and they're just applying for OPWDD, you're going to want to also create a paper trail to show that there were these challenges prior to 22. And that could be old school records, pediatrician reports, early intervention evaluations, CPSC evaluations. But that's why if I'm working with a child, it is easier to start the process prior to 22 because it's one less thing that you have to prove. If you are applying for services for CPSC, so CPSC is going to be from 3 to 5, 5 to 21 would be the DOE. They're going to do a lot of their own testing. They're going to require the child to have an updated physical. They're going to typically do a social history. They're going to do some IQ testing or developmental assessments. And then depending on kind of what service you're looking for, they might do their own school observation. If your child is between 0 and 3, the good news is that they are going to be getting services through early intervention, and early intervention also does their own evaluations. CPSC and DOE will accept private evaluations. Early intervention will do their own evaluation. You can get a private evaluation, but they're still going to they're going to rely on their own evaluations to determine if a child is eligible for services through the early intervention model. If you are a New York City family and you are looking at alternative placements for your child, so outside of the New York City DOE, um, those schools can sometimes have separate requirements that they're looking for. So oftentimes they will ask for additional testing. They will ask for an IQ. They will ask for academic functioning, adaptive behaviors. And some schools I've heard of, like some of the private schools, are also requesting kind of more personality assessments or behavioral assessments. It's important. Again, I'm sure we have parents on here of all different ages or individuals who work with clients of all different ages. Testing should be developmental. So when we're thinking, if you have a child from 0 to 3, we're really thinking about developmental assessments. Those gross motor skills, those fine motor skills, babbling, like those very basics. In preschool, those 3 to 5-year-olds, we're really thinking about language skills, motor skills, because those are the things that are going to impact the student the most in their academic setting. School age children, we're starting to think about attention, auditory processing, executive functioning. So, executive functioning is like that frontal part of the brain that helps us with organization, prioritization. Those are all things that become more important in those middle school years, high school years for learning. And then in adulthood, we're thinking about more personality assessments, job readiness, job placement assessments, because we always want to think about what is impacting the individual in their developmental context. So if I'm testing a 4-year-old, I'm not going to be testing their executive functioning skills because at age 4, no child's executive functioning are well developed. So taking a look further in terms of the different types of evaluations. So diagnostic evaluations is what I do the most. And again, as I mentioned, a diagnostic evaluation is just looking at yes or no to autism. And another question I often get from parents is my child was diagnosed with PDD-NOS, or a psychiatrist told my child that they have Asperger's disorder. Any psychologist, psychiatrist, developmental pediatrician, neurologist giving a child an autism diagnosis in the current time should be just using autism spectrum disorder. So psychiatrist, psychologist, neurologist all use something called the DSM when making a diagnosis. So in 2013, we went from the DSM-4 to the DSM-5. The DSM-4 had different categories. In the DSM-5, there's only one category, autism spectrum disorder. And this decision was made based on a large research study that looked at how accurate clinicians were in making an autism diagnosis. And they showed that clinicians were really accurate in saying yes or no to autism. But there was a lot of variability between different sites of when children were getting these different labels. So what that showed us was they weren't really being used meaningfully. And that was part of the reason for kind of just creating the autism spectrum disorder. Individuals will sometimes say to me, I have Asperger's, and I will never take that identity away from an individual. But a clinician and in a psychological evaluation or a written report, if you see a professional writing PDD-NOS or Asperger's, that should be a red flag because at this point, those are no longer diagnoses. And when we're talking about autism spectrum disorders, we're talking about symptoms across 2 different domains: social communication difficulties and restricted repetitive behaviors. And these are the things that we're looking at when an individual is coming in for a diagnostic evaluation. So this is I would say, very confusing still. Who can diagnose autism? You do not need formal testing to diagnose autism. You do need formal testing if you are applying for services through OPWDD if you're applying to try to get your child into the New York City Nest program. So there are some situations where formal testing is necessary. However, as I just mentioned, autism is a behavioral diagnosis. It is a diagnosis based on somebody observing an individual's social communication skills, restricted interest, repetitive behaviors. Just like depression, just like anxiety, where yes, there are standardized measures that we can give to quantify those things. But oftentimes a psychiatrist will just give them based on observing an individual and getting their history. So who can diagnose autism? A psychologist diagnoses autism using standardized assessments. A psychiatrist can diagnose autism based on thorough clinical interviews. Neurologists are very equipped to diagnose autism, as well as developmental pediatricians. And each profession might diagnose it slightly differently. Typically, psychologists are the ones that are doing the ADOS, but the ADOS does not require it to be a psychologist that administers it. So I do know of psychiatrists that have gotten trained on the ADOS and use it in their practice. So in theory, any of these individuals can also give the ADOS. In New York, it's typically psychologists that are doing the ADOS. But again, if your child's neurologist gave your child an autism diagnosis, you should feel okay about that if you trust your child's neurologist. Um, so sometimes people will call me and say, my psychiatrist gave me a diagnosis, but I want to have formal testing. And we'll talk about it and understand why. And if it's just because they're questioning they were told that they should get an ADOS if they have autism, we'll discuss it, but you don't need an ADOS to get a diagnosis. Lots of people will get a diagnosis from one of these other professionals, and it is a very valid diagnosis. So again, psychologists, psychiatrists, neurologists, developmental pediatricians are all using this DSM. And it's not this magical thing. I always like parents to see exactly what these professionals are using to say yes or no to autism. So the diagnostic manual says an individual has to have 3 of 3 symptoms in the social communication domain, 2 of 4 symptoms in the restricted repetitive patterns of behavior domain. Symptoms have to be present in early childhood, but don't have to fully manifest until later on. And symptoms have to impair everyday functioning. So what are those symptoms? In the social communication domain, it's difficulties in social emotional reciprocity. So in our preschoolers, it's difficulties with turn taking, sharing. In our school-age children and adults, it's difficulties having true back and forth interactions, whether that be kind of engaging back and forth or having more conversations back and forth. Difficulties in nonverbal communication. That's difficulties in eye contact, not making eye contact or staring too much. It might be difficulties in having your face and using facial expressions to communicate your internal feelings. So I have some adults that will say, oh, everyone always says I'm angry, even though when I'm happy. Or I have parents saying, when my child is really anxious, they start laughing. So kind of that discrepancy between the internal state and what they're communicating via their facial expressions. Um, Lack of gestures. So in small children, that might be not pointing or not waving, not using hands to say, pick me up. In adults, it might be very stiff gesturing or not gesturing at all. I also have some individuals who kind of have learned to gesture, but then are kind of over gesturing or kind of almost seeing like they're on a theater and kind of it's like very exaggerated. Difficulties in nonverbal communication can also be difficulties reading other nonverbal cues. The last category in this kind of domain is difficulties in developing and maintaining relationships appropriate to developmental level. So again, when we're talking about really young kids, it's like, do they show a preference for some kids over others? When I'm talking to my high schoolers or college students, it's, are they developing and maintaining friendships. Are they reaching out to their friends? Do they have an understanding of what a friend is? So we're always looking at that developmental level, kind of thinking about their understanding. And again, for an autism diagnosis, an individual has to have all three of these. In terms of the second kind of domain, that restricted repetitive pattern of behavior, an individual only has to have two of the four, which explains some of the kind of variability that we see across the spectrum. The first are stereotyped or repetitive speech. So this could be a child who has echolalia and is repeating back what they heard. And that could be fairly immediate, like almost like a parrot, or it could be fairly delayed, where let's say their parent comes home and says, "Guys, I'm home." And then every day after that, the child comes through the door and says, "Guys, I'm home," in the exact same intonation. That is what we call echolalia. It could be more scripted speech. So where they're kind of saying whole lines from TV shows, movies, books, video games, and kind of repeating it and using it as their own. We can also see motor mannerisms, so hand flapping, toe walking, spinning, pacing in a kind of a pattern, um, or repetitive use of objects, so kind of throwing things down or kind of playing repetitively with things. The second kind of behavior is excessive adherence to routine. So this might be a child who needs to go to the same route every day to school, and let's say there is construction and the bus deviates, they start having a tantrum. I've had kids that will really struggle when there's a substitute teacher, or even on like a snow day, which most kids think of as a very happy day. These kids struggle because it's kind of an unexpected change in their routine. You can also see kids or individuals who have ritualized patterns of verbal or nonverbal behaviors, kids who need their parents to kind of go through a verbal ritual with them, or kind of need things to be in a very specific order around bedtime or they can't go to sleep. Difficulties with transitions, difficulties with changes in their environment. I once did an evaluation on a child, and the first day I was wearing my hair up, and the second day I was wearing it down, and just that subtle change in someone that they'd only met one time caused distress. So it could be any of those. The third are unusual or intense interest. So these can be a child who gets super fixated in the transit system or super fixated on dinosaurs. So those are very common interests for lots of kids, but these individuals kind of get very fixated. That's the only thing they want to do. That's the only thing they want to talk about. Or you can also see some kids who have an interest in vacuum cleaners or ceiling fans. And then the last, which is a newer symptom in the DSM-5, are sensory, either sensitivities or sensory seeking behaviors. This could be sensory sensitivity to food textures, noise, light, clothing. It could be sensory seeking behaviors, a child who uses a weighted blanket or who's constantly needing like deep pressure hugs or who's bringing things close to their eyes to get more sensory input. Again, there's so many behaviors that fit these things. I didn't go through an exhaustive list, but in order to meet DSM criteria, this is the kind of what any clinician, whether it's psychologist, psychiatrist, neurologist, developmental pediatrician, is utilizing. Another thing to be aware of when you get a diagnostic evaluation using the current DSM, we no longer use the different categories, but we do use levels of support. So there's 3 levels of support in the diagnostic criteria. Level 1 means you require some support. You're able to function maybe in a mainstream setting, you're able to work, you're able to participate in college, but you need some support, some accommodations. Level 2 is somebody who needs more supports than that. And level 3 is somebody who needs like very substantial support. So they need really specialized programming for their autism behaviors. And at least at our center and what you're supposed to be doing, I don't necessarily know if every clinician does this, is you differentiate what support somebody needs for social communication and what support somebody needs from restrictive, repetitive behaviors. And levels of support are not meant to be something that can't change over time. So for a child who might need a one-to-one aid because they get so stuck, they might be a level 2 or level 3 support in the restricted interest repetitive behaviors. But maybe they're fairly independent in their communication skills. Maybe they're verbal and they're able to have conversations. So maybe they're a level 1 support in their social communication. So the idea being these levels of support are not meant to kind of be something that a child can't change, but they're meant to provide the reader with an understanding of what type of support a child might need. So, in terms of when we're thinking about autism specific measures and screening tools, hopefully everybody here, if you have a child who's 18 months or older, have done the MChat. That is a tool that's supposed to be used during well child visits with their pediatrician. For older children and adults, some screening tools. Again, these are not tools that are accepted by OPWDD for an autism diagnosis, but these are screening tools that if a child score is elevated on, would make a clinician think maybe we should be doing more formal testing. For older children, it's the social responsiveness scale, social communication questionnaire. Here's the MChat. Again, on the MChat, this is a free assessment, which is why it's used in pediatricians' offices. And there are key questions that if you answer, kind of would alert the pediatrician to kind of elevate screening. So whether that's a referral for EI, CPSE, or a private evaluation. So these are the second level autism evaluations. These are accepted by OPWDD. So the ADIR, the Autism Diagnostic Interview, is not commonly used. It's mostly used in research. The reason why, it's a 3 to 4 hour parent interview. And while it can be really helpful, it's very kind of time consuming. The ADOS is fairly well used in making an autism diagnosis. That's what you see below, and I'm going to talk a little bit more about the ADOS, as well as the childhood autism rating scales. So in terms of the ADOS, there are 5 different modules based on language ability. The ADOS, which was developed by Kathy Lord, is not meant to be used as a standalone assessment. So it is not like a strep test where you do a culture and it's like a clear yes or no. The ADOS is used along with clinical judgment. You score behaviors. There are cutoff scores that help a clinician understand, is autism more likely? Is autism less likely? But I have patients that score really high on the ADOS where they don't have autism. They're scoring high because they have ADHD. They're scoring high because they have severe depression. And I have some individuals who score below the cutoff on the ADOS who do meet for autism. These are typically individuals that have very high IQs, are high masking, meaning they've learned how to adapt. You need to score above the ADOS cutoff to qualify for OPWDD services, though. So for those adults that I'm evaluating that are scoring below, but I give a clinical diagnosis to, they are not eligible for OPWDD services. A newer tool that came to be within the past 10 years is called the MIGDAS-2. The MIGDAS-2 has less research behind it than the CARS and the ADOS. It is more neuroaffirming, so there's a lot more feedback from autistic adults that it feels more comfortable. And the MIGDAS, there's a child protocol and adult protocol. It's more conversation based, but it does get at similar things of the ADOS, looking at social reciprocity, looking at nonverbal skills, looking at sensory seeking. But I always like to include it, but I guess I'm not, and again, I don't know if OPWD is currently accepting the MIGDAS. I haven't been to their website, but it is a newer tool that's definitely gaining popularity on if you're on any autistic self-advocate social media platforms. So that is a diagnostic assessment. So if you're calling a center like ours or NYU and you're saying, I want a diagnostic assessment, they are typically going to be doing a psychosocial or that clinical history and the ADOS, because those are the two things that are needed to understand if an individual has autism. You don't need a neuropsych to diagnose autism. If an individual is calling and saying, I need a psychological evaluation, what that means is a history, a record review, a parent interview, a child assessment, and a feedback session. Psychological testing always includes some kind of cognitive test or an IQ test. There are comprehensive IQ tests. Those are going to be the Wechsler scales, the Stanford Binet. The DAS has gained popularity because it's a little shorter. For our individuals who are non-speaking, we have nonverbal IQ tests. Those are going to include the lighter or the C-Tony. For those that are applying for OPWDD, for an individual who is non-speaking, OPWDD requires the administration of a nonverbal comprehensive test, so like the nonverbal portion of the Stanford Binet, in addition to a nonverbal assessment. Developmental assessments are typically used for our young ones, and for our young ones like 0 to 3, 0 to 4, you can get kind of IQ tests. There are some individuals that I work with that are non-speaking, that have significant developmental delays, and we attempt comprehensive testing. We might attempt nonverbal testing, and if they really are not answering any questions, then we might drop down to a developmental test. If you are giving a developmental test to a child above age 5, you are no longer getting an IQ score, you are getting an age equivalent. So the Wechslers, the Stanford Binet, the DAS, the lighter, the C-Tony will say, is your child average, low average, borderline, impaired? Once you drop down to a developmental test, you're no longer going to get those kind of descriptors for a child who's over age 5. You're going to get the child is functioning at a 4-year-old level, or a child is functioning at a 2-year-old level. But so I think it's important for parents to understand that, and also to read, if you are applying for OPWDD as a parent or an advocate, to know what the OPWDD is going to require. Because if a psychologist starts, let's say there's a 10-year-old who's non-speaking, and they start at a developmental assessment, and OPWD reviews that, they might say, well, why did the psychologist not try a standardized assessment that was more age appropriate? And again, that doesn't mean that your child has to sit there for a full hour IQ test, but the psychologist needs to at least document that it was tried and that the individual did not answer any questions and it was no longer appropriate. So understanding the report. So when you get a write-up of your child's IQ, typically if it's not a developmental assessment, or if it's a developmental assessment for a young child, you're going to get a full scale IQ score. And depending on what test, it impacts kind of what that looks like. But the full scale IQ score is just an average of the components of the full scale IQ. So if there's a lot of variability, which we do see often in our patients, sometimes the full IQ doesn't accurately represent what the child is capable of. So I'll give you an example. If a child's verbal skills and their visual spatial skills are high average, and if the child, let's say, working memory and processing speed is impaired, the full scale IQ is going to be an average of that. So the child's full scale IQ might show borderline. But that's not really capturing that one number, or that one kind of comment doesn't fully capture the child's capabilities, because they have some things that are average and some things that are really low. So I think sometimes as a society, we get so caught up on that, like, what is the child's full scale? What is the child's full scale? And if for a child who's kind of even across domains, that full scale IQ is accurate. But for a lot of the clients I work with, there's significant variability. And I don't want parents to get hung up on that full scale because that full scale is just an average of their skill sets. So it's much more helpful to say, my child's verbal skills are here, my child's nonverbal skills are here, my child's working memory is here, my child's processing speed is here. Because again, I think that sometimes parents will see that number and kind of have a significant feeling one way or the other without understanding that it's really just an average. A psychological will include the IQ testing, and it will always, especially if you're applying for OPWD, it needs to include a measure of daily living skills. The two common ones are the Violent Adaptive Behavior Scale and the Adaptive Behavior Assessment System, the ABAS. This is a parent interview. Psychologists are not observing your child and making these assessments. The psychologist is asking you questions about your child's daily living skills, either through an interview or through a survey. And they put your responses into their computer system and it spits out the score. When parents answer this, and I get it, I'm a parent myself, we always like to think about our child in the best light. We want to talk about what things they can do. However, if you are applying for services and there's a significant difference between your child on their best day and your child on the worst day, from a service perspective, you want to think about your child on the worst day. So if your child on the best day wakes up, brushes their teeth, no problem, but that's once a month, that's great. And you might want to anecdotally tell the psychologist, well, my child has shown that on occasion they can wake up and brush their teeth without prompts. But if most of the time you are standing there saying, okay, turn on the water, brush your teeth, or maybe you're even doing hand over hand because they don't brush that well, that is not a child who's independent in brushing their teeth daily. So oftentimes parents might get denied OPWDD services, even though their child has autism, but because their daily living scores on these measures were not low enough. And unfortunately, not all psychologists provide that information before. But if you are ever filling out a measure of daily living skills, I want you to kind of script through your head, my child on their worst day. What level of support does my child need on that day where they wake up on the wrong side of the bed? Maybe there was this unexpected change, and they're going to need to get through the day. I will say often, especially if you're applying for OPWGD and using like a agency like Synergia, YAI, a psychological will oftentimes also include the ADOS, or it might be a separate appointment. But like when somebody's coming to our center and we're doing a psychological, it always includes IQ, adaptive measure, and ADOS. But typically, if somebody's just asking for a psychological, you'd want to make sure that the ADOS is being done. A psychoeducational evaluation, again, you're going to see a theme. All these just build on each other. Includes cognitive testing, includes that measure of daily living skills. But now we're adding achievement testing. So now we're looking at, is the child on grade level? It's also typically going to include behavioral assessments. Psychological testing, IQ testing, and achievement testing can be done through the DOE, and you're entitled to get evaluations through the DOE if you're seeking services such as an IEP or want to see if your child qualifies for a 504 plan IEP. I will have families who might come to a center like ours for the ADOS and then we'll supplement testing so they don't have to pay for it with the DOE academic testing or IQ testing. I have some families that will also say, I don't want the DOE to be doing the testing. I want to have an independent evaluation. But you can get creative thinking about how do I get the most accurate results? How can I be the best advocate for my child without kind of breaking the bank? because if you do have to go privately for any of these evaluations, um, it can be pretty costly. So in terms of achievement testing, there's achievement testing depending on how old your child is, right? So if your child's like that preschool age, they're looking at the Bracken School Readiness Test. It takes 15 minutes. It looks at letters, numbers, colors. For some of my non-speaking friends that I work with, they might not be speaking, so they might score low on some of the other measures, but maybe they're really good at letters and numbers, and I want to capture that. So I might give them the Bracken School Readiness Assessment to just really capture um, what their strengths are. The RAT5 is something that's often used as a screener. It's not super comprehensive, but it kind of gives us a general sense of reading, writing, math. The more comprehensive achievement tests are the Woodcock-Johnson or the Wechsler Individual Achievement Test. And again, you could do lots of testing in those. You can kind of take a few of the subtests. If there's specific concerns about dyslexia or other learning differences, there might be more specific tests. So like the gray aura reading test, the test of written language looks at like, can a child organize their thoughts? What's their writing look like? So again, this level of testing is really helpful if you think there's like an underlying learning difference. And that's where this will be helpful. You do not need psychoeducation testing to diagnose autism, though. Psychoeducational testing will help understand where your child is in terms of grade level and in terms of academic functioning, and can be helpful in terms of IEP if you feel like they need more supports in a specific subject area or need additional supports in the classroom. In terms of understanding the report for academic functioning, you might see terms like phonetic awareness, decoding. These are things like, can a child hear a sound and know what that sound is? Are they able to sound out words? Reading comprehension is the ability to understand what you read. Math, computation skills is one's math skills. There's also fluency. So fluency, if you see math fluency, reading fluency, that's how quickly can you do something. So there are students that are really good at reading comprehension and really strong at math computation skills. But once you say, do this really quickly, they fall apart. Writing and also in academic functioning, you're going to start seeing attention because that's part of academics. Behavioral assessments that are often part of the psychoeducational system. You might, if there's concerns about ADHD or if a child's really inattentive, you might see the Conners, you might see the brief. The child behavior checklist looks at kind of overall behaviors. The BASC also looks at overall behaviors, internal behaviors such as anxiety, depression, externalizing behaviors such as aggression, things like that. Neuropsychological evaluation. So I get so many calls from parents saying, I need a neuropsychological. Most parents do not need a neuropsychological. So there are some families that neuropsychological testing is indicated. Neuropsychological testing is the most in-depth testing. We're talking about 8 to 10 hours of testing for your child. Typically, a neuropsychological evaluation includes cognitive testing, that IQ test. It includes academic testing, and then it includes specific tests to look at specific brain functions. So it might look at attention, language, auditory processing, executive functioning, visual spatial skills more in depth, memory, motor skills, social skills, and emotion perception. If your child is non-speaking or has been diagnosed with an intellectual developmental disability, unfortunately, our neuropsych measures are not great at kind of making accurate diagnoses in those individuals. Because what's going to happen is if their IQ is in the impaired range, on all these measures, they're going to be impaired, and it's not going to give us a strong sense of what their strengths and weaknesses are. Neuropsych testing can be indicated if there's been a significant change for any reason, if there's significant concern for ADHD or a memory concern. So there are some cases where neuropsych testing definitely is indicated. But neuropsych testing, like if a family wants neuropsych testing and insists on it and we do it, is helpful for providing additional information, but it doesn't help us diagnose autism. So I know if a child has autism, they're going to do poor on social skills and emotion perception test of a neuropsych assessment. But having poor social skills, emotion perception doesn't mean a child has autism. So the most common childhood neuropsych measure is the NEPSI. There are other tests specific for attention. The Integrated Visual and Auditory Continuous Performance Test is a computer test where a child has to kind of respond um, and press keys based on what they're seeing on the screen. There's specific tests for executive functioning. So the DCAPS, the DELS-CAP, and Executive Functioning System is one of the more popular ones. And again, if these are true deficits outside of autism, it could be helpful. But I could tell you most kids with autism are going to have poor executive functioning skills and do worse on those social emotional assessments of the measures. Language testing can be part of a neuropsych test, visual spatial testing, memory testing. Sensory motor can be part of a neuropsych measure. If you have concerns about sensory motor, though, you can also have an OT evaluation. You don't need a neuropsych measure if there's specifically fine motor concerns. Just like if you just have language concerns, it might be getting a psychological and then getting a speech and language assessment. So there are lots of creative ways. You always want to think about what is my goal. So if my goal is to see if my child qualifies for OT or speech services, rather than getting a neuropsych, you might request a speech eval or an occupational therapy eval. Neurological evaluations. So a neurological evaluation is done by a medical doctor, by a neurologist. A neurological evaluation looks more like a medical exam. They're going to be doing a mental status. They're going to be looking at sensory aspects such as sight, hearing, smell, touch, taste, movement. They're looking at reflexes, sensations, balance, and coordination. They're going to ask you to do different things, stand on one leg, walk a straight line. Um, Lots of neurologists in the New York area feel very comfortable and give accurate autism diagnoses. I always recommend a neurological evaluation if there's been a significant regression in skills for an individual. If there's any concern in seizure activity, that is dealt with by a neurologist. So those are two cases where even if you're getting a psychological, psychoeducational, you would want a neurological evaluation if there's been a significant regression in skills and if there's any concern for seizure activity. Those definitely fall under neurology. A psychiatric evaluation is conducted again by a medical doctor, a psychiatrist. These evaluations are going to look more just like a talk therapy session. The psychiatrist might talk to the individual, the psychiatrist might talk to the parent or other family members, the psychiatrist might reach out to the school. They might include some of those kind of measures. They might include a Conners or they might include the brief. They might include some of those autism screening tools. They obtain a really thorough developmental history. They might get medical history. They might look at lab tests. They might do blood tests. They might ask to see a psychological assessment or look at school records. And then they make a diagnosis based on that. Oftentimes, if I am seeing an individual for autism and I also have concerns for depression, anxiety, bipolar disorder, anything of that nature, that would be a reason to also get a psychiatric evaluation because a psychiatric evaluation is going to look more broadly than a diagnostic evaluation. A psychiatric evaluation is going to say, yes, this person could have autism, but is there another DSM diagnosis that might be happening in addition to autism or that might better explain these behaviors? So now that we got the report that we want, what do we do with it? So we hopefully, whether you've gotten a psychiatric evaluation, whether you saw a developmental pediatrician, whether you had a psychological evaluation, you get a written report with the doctor's diagnosis and recommendations. Now, what do we do with it? One thing to understand, no single test is used to make a diagnosis. So that's true in neuropsych testing, that's true on the ADOS. We're looking at a pattern of behaviors of scores over time, right? And no single score represents an individual's strengths or weakness. Another thing for parents to focus on is most psychologists, psychiatrists, neurologists understand the service system. And when we're writing a report, we are writing a report to help your child or client access the services that we feel like they need. We are going to use the medical model, which is more deficit based. And I know parents will say, like, this, yes, I'm reading it, but it doesn't capture how amazing my child is or that they're so skilled in this. And it's not because that the professional didn't understand that, but if we wrote a report saying all the amazing things that your child does, it would make it harder for the DOE or OPWDD to justify them getting services. So I think I get that as parents, you don't want to see your child in just all the negatives, but when an individual is writing the report, they're thinking about this parent is going to the DOE with this report and I want to get them services. Or this family is applying for OPWDD and I want to make sure that they qualify for the supports that they're going to need. So I think that's also important to keep in mind. So I mentioned this at the beginning and I'm going to kind of end with this idea. So a diagnosis is like a key. That is all it is. It is a tool that you use to help you get the services you want. It does not define who you are. But that is why I find most of the families that I do evaluations for are getting the evaluation because they need a diagnosis to access services. Another thing about a diagnosis does not map onto an IEP classification per se. So clients might get a diagnosis of autism and have an IEP classification of other health impairments. A client might get a diagnosis of autism and have an IEP classification of a speech and language impairment. The only time an individual needs an autism classification is if they're getting like an ABA based support in school, if they're part of the New York City Nest program or Horizon program. But a classification doesn't necessarily map 100% to a diagnosis. The important thing is that the services and supports that your child are getting are right for your child. So I know sometimes parents will say, how can I get my child classification changed? And if you're happy with the setting and the services, you don't need to get their classification changed, especially if you're in some of those alternative New York City schools. Some of them might not be equipped or funded to handle certain classifications. So that's why your child's classification might be the way it is. So I think of the diagnosis as a key. The evaluation is your roadmap. The evaluation and the recommendations made on the evaluation should help guide you in terms of your advocacy for your child. But we're going to talk a little bit about that in the next slide. Another important thing to remember is having a diagnosis does not automatically qualify an individual for services. So if a child has autism, but is functioning very well academically, there are no behavior issues, no emotional concerns, they might not qualify for a 504 plan, or they might not qualify for an IEP. The school districts are looking to see how does this diagnosis impact the child's ability to learn and impact the child's ability to function in the school setting. So that's also helpful to remember. When we're thinking about recommendations, we want to think about your child's strengths. What are the things that they're really good at that we can use to build on skills? And what are they weaker at? Where do they need more supports, accommodations around to help them? So we want to understand the report thoroughly. After our feedback session with the provider, we should have a sense of what are my child's strengths? What are my child's weaknesses? And that's something you can ask that question. I think that is a very valid question for a parent to ask the individual who did the evaluation. We then want to connect the findings in the report to functioning needs. We want to be specific how difficulties would manifest in the school or vocational setting or day program. Because at the end of the day, the school doesn't really care if your child has slow processing speed, but they care that your child has slow processing speed, need more time on assignments, and therefore would qualify for extended time on exams. Or that your child has dysgraphia and has a hard time writing, so would qualify or should be able to use a keyboard. Or let's say gets overstimulated from their sensory environment, so needs the ability to take sensory breaks, has access to noise canceling headphones when doing independent work. Um, if your child has difficulty writing, then maybe they need extra writing prompts, or they need use of visual organizers, or maybe they need more one-on-one support in writing, whether that's through a resource room as a push out or a push in. So the evaluation should really help guide our goal setting, and that's going to be across the lifespan. If you feel like there's been a change in your child's functioning, maybe their IEP worked really well last year and this year you're noticing like things are not going so well or my child's struggling more. As a parent, you can request or challenge evaluations when needed. You have the right to ask for updated evaluations from the Department of Ed. If you feel like Department of Ed evaluation is not accurate or is biased, you can seek an independent evaluation. In some cases, the DOE has funded independent evaluations. Um, I mentioned that evaluations can be costly. We live in the tri-state area. Fortunately, there are lots of agencies that do evaluations and help families apply for OPWDD and offer evaluations for those families free of charge. There are also lots of centers that do research, including CADB, where I work in White Plains, the Seaver Autism Center in Mount Sinai, on Uptown. There's the NYU Child Studies Center, the Child Mind Institute, all do research studies. And if your child qualifies for a study, there would be the opportunity to get an evaluation free of charge, not through insurance, but through participating in a research study. Another important thing through advocacy, and this is going to be advocating through OPWDD, advocating with the school district, advocating with Access VR, document everything. Have a notebook and write down every call you make, every email you send, who you spoke to, what they said, and create a paper trail. And the last thing in terms of using your evaluation to advocate is building a team of support. I have been on numerous IEP calls for families where I did the evaluation. It's based on availability. But if I did an evaluation, a family says, we don't really have that many people to kind of help guide us. Can you hop on a call for 30 minutes for the IEP? And the school agrees. I'm always happy to do that. So ask your child's treatment team, whether it's independent providers or through an agency, if they can be part of the call or if they can write a letter in support of additional services. So build a team and use them to help you advocate. Um, I'm going to now open it up for questions. And I will say, in cases where you feel like the school is not meeting your child's needs or they're not following the recommendations made on the report, There are agencies that help you provide educational advocacy and will help you understand your rights. Include NYC is a really big one. They have free information on their website. They also do like one-on-one consultation. If you end up needing like more legal advice, there are agencies that offer free legal counsel. They don't take every case. They take cases based on an individual basis. Um, and then obviously there are lawyers that do charge. Um, so that would be a route to go if you're feeling like you have done advocacy, you have a report that says what should be done, and the school is not kind of meeting your child's needs. I will also say the IEP meeting sometimes is a little bit of negotiation. So I know when I'm writing a report, let's say I think a child should be getting speech therapy 2 to 3 times a week. In the report, I might say 4 times a week because I typically know that whatever I write, the school is going to try to come back and say, okay, let's do twice a week. So I know if I kind of put more than what I think their child is going to get, we might end up at that happy middle. So there is somewhat of a negotiation. So it's not like if you have a report saying the child should be getting this, that the school district is going to say, okay, great, here's everything that your report asked for. There's going to be some back and forth, and that's where having the person who did the evaluation or independent providers that know your child well can be really helpful for you.
Awesome. Thank you, Dr. Gorenstein. So before we jump into the Q&A, I'm just going to stop the recording. So I want to say thank you to those that joined via Facebook Live. Alrighty.